Hello, welcome to Heart Month on Open Heart Surgery with Boots. I am your host, Boots Knighton. Please give a gigantic welcome to Dr. Kelly Sadauckas, who is coming at you today from Driggs, Idaho. I am down in Victor, Idaho. Kelly and I have known each other for quite some time, and both of our lives have taken all kinds of interesting and winding paths. And here we are today and for the month of February to bring you a whole series on the pelvis and pelvic health. And I could not be more excited. And this is coming on the heels of my 4-year anniversary of open heart surgery.
Oh my gosh, I can't believe that, Boots.
And I am just astonished that just now, at 4 years, I am finally learning about what it means to have a pelvis, to take care of the pelvis, what is a healthy pelvis, because lo and behold, thanks to you, I just recently learned that open heart surgery affects the pelvis and pelvic health.
It does.
So, I wanted to bring you on for the whole month of February for Love Month and Heart Month.
Love Month. What is more love than the heart and the pelvis? Right? They're like the two primary pieces in Love Month. So thank you so much for having me, Boots. So a little more about me, guys. I am a pelvic health physical therapist. I have been in pelvic health my entire career, which is about 25 years now. And I feel so blessed and in this calling. I really do consider it a calling to reach people and helping people understand their pelvis and their pelvic health and helping them pee better and poop better and have more fun in the bedroom. When you can help someone with those things, you help them on such a deeper, more holistic level than just helping them with their shoulder pain. So it's been such a personally fulfilling journey. As with many other pelvic health PTs, probably about 10 years into my career, I was feeling a little overwhelmed and burned out with patient load and having a huge wait list and dealing with the insurance game. And so many people needed my help. And I often had a wait list of 2 to 3 months for people to come in to get help from me, and we'd often help them in just 1 or 2 visits. So I began to think, what can I do to reach more people? And through a circuitous, amazing journey, in 2020, I launched Pelvic Floored with the vision to change the world one pelvis at a time, starting with you. And how we're going to do that, the mission is to reduce geographic, financial, psychosocial barriers to accessing this information about pelvic health. And Boots, 4 years into your journey, you're just learning about this. I meet physicians that are 50 years into their successful medical practices that have never understood the relationship of pelvic health to the whole body. And so you are actually ahead of the game for most, and I am so grateful that your listeners here are going to get to learn about the pelvic floor and the heart here in February, Heart Month. Ooh. So today, though, before we get into all those deets, this is pelvic floor 101. What the heck is a pelvic floor, right?
Right. Yeah, what is it? And so, listeners, I've asked Kelly to just treat us like we are starting from scratch and treating me like I have just shown up in her office for the first time. And we're going to take it from there. So this is we're not skipping over anything. I have not seen Kelly for my pelvic floor, although I do need to. And
Call me.
I'm just going to be overt about that. And that is okay. This is going to be a series of it's okay to talk about weird and awkward things. It doesn't have to be weird and awkward, but if we're thinking about one of the impetus of me starting this podcast was I didn't get instructions on how to heal completely from open heart surgery. it was only focused on the heart and the chest, and it didn't include the emotional, spiritual aspects, and it definitely didn't include the pelvic floor. It didn't include nutrition, which is why I had the whole series in October of 2024 with Michelle. And so the whole point of this podcast is to help you find healing, mind, body, spirit, head to toe, front to back.
Amen, sister.
So we're starting from scratch. I'm starting with you, listeners. So, all right, Kelly, I just
love
walked
it.
into your office.
I love it. Okay, let's dive in. So if you were seeing me or another pelvic health physio in person, we would do a detailed medical history about everything you've gone through in your life, right? What surgeries have you had, etc. We would dive into, if you have a vagina, into your menstrual history as well. When did your periods start? How regular were they? Were they painful? We then are going to ask questions about pee, poop, and intimate functions, regardless of what type of pelvis you have. And based upon those answers, then that guides the rest of the visit. So Boots, you and your listeners, we're going to just go through, number one, what's normal. And then we're going to talk about the anatomy and like how of the bones and the muscles and how they work to provide that quote unquote normal function. And then we'll get to the nitty gritty of what's not normal. And, what's not normal might be ludicrously common in this world of pelvic health. But that doesn't mean that we have to deal with it, right? The incidence of pelvic problems, so pelvic pain, problems with peeing and pooing, it is the same incidence as back pain in the world. 8 out of 10 people will suffer from some type of pelvic problem in their lifetime. But here's the thing. When you have back pain, the average time that it takes you to get care is 2 to 3 weeks if it doesn't resolve. If you have a pelvic problem, pain, pee urgency, pee leaks, poop problems of constipation or loose poops, sexual problems, your average a time before you seek care is 5 to 7 years. And I would honestly argue that that's 5 to 7 years for someone with a vagina, and someone with a penis might even go longer than that for a multitude of reasons. And it's because we think it's a normal consequence of aging. It's because we're ashamed and we feel alone. And then worst of all, if we go to ask for help and we're told by a medical provider that it is normal, and it just stops our ability to progress, which is so sad. So I'm so grateful to be here to talk to you about these things to, number one, improve awareness. Number two, encourage you to get your cute butts in for help. And then number three, we might even save some lives by learning about a few pelvic changes that are shown to exist before heart issues. Oh my gosh. Are we ready?
I am so excited. I feel like I need to get like school supplies ready and like, I've got my notepad. And yes, and we're going to be saying penis and vagina and sex, like it's all the words that go with the pelvis. And I hope that if you are listening to this and you're already like feeling squeamish, I invite you to sit with the discomfort, because what I really want for you is complete and total health. And that includes your pelvis, and it includes your vagina and your penis. Can I say that?
Yes, girl. And we should do a whole nother talk about, I think the Latin origin of the perineum is like that shall not be named or something. Oh my gosh.
Wow.
So then there's a whole nother talk about like purity culture and stuff, but that's for later. So first and foremost, folks, what is normal in the pelvic floor? Because to understand what's not normal, we need to start with the basic ground rules of what is normal. Regardless of your age, regardless of what parts you have in your pelvis, we ought to pee on average once every 3 to 4 hours while awake. And when we pee, it should be preceded by a gradual urge to pee. Never a freight train. Hey, get your butt to the bathroom right now. No. It should start as a whisper that gradually builds up, that we eventually listen to on our own terms, When we start the stream, it should be very easy to start the stream. To maintain the stream of pee, that stream should last at least 10 to 15 seconds of a nice healthy stream per pee. Following the stream, we should either give it a wiggle or a single wipe and be able to stand up if we're already standing, tuck things in, have no post-void dribbles, and then the cycle resets. There should never be any pee leak. There should never be leaks that are there should never be any leaks associated with urgency, jumping, laughing, coughing, sneezing. That should really never happen. When we finish peeing, we should feel satisfied. We should not feel like it burns when we pee or that it burns afterwards. In general, we should actually sleep through the night without awakening to pee. And this is something that is considered normal as we age, or doctors will even say it's normal during pregnancy to get up at night to pee. And I would beg to differ. Like, maybe we'll give you one pee a night by like your third trimester, because then baby actually is settling down, possibly in the first trimester because of the increased blood flow. But in general, I want you sleeping. The importance of sleep for overall holistic health cannot be overestimated, and I want you to sleep whilst still being hydrated. So yes, there are a few caveats within this, and I don't want you to dehydrate yourself at all, because hydration is important. So if I go through my whole day and I haven't drunk enough water and I drink 32 ounces right before bed, in that particular case, I might need to pee at night, and it's better to be hydrated and wake up once and pee. But if I'm only drinking 30 ounces during a whole day, like, that is woefully inadequate. I should not be waking up to pee that night, but I might be, because I might be dehydrating my bladder. But I'm getting ahead of myself a little bit. It is. And so all of that pee function should occur with us drinking this normal amount of water, which we take our body weight in pounds and we divide it by 2. So I weigh 160 pounds, so I should be drinking at a base level 80 fluid ounces every single day. 75% of that should be non-caffeinated, non-alcoholic. Really, alcohol is just a chemical shitstorm. Like, we should all be avoiding it at all costs. Yeah. And then if I am living in a high, dry mountain climate, if I'm exercising, that base amount needs to go up a little bit. So am I having all those normal pee functions while being adequately hydrated? That's a really important thing to check. Poop. The same muscles that control the pee function also control poop function. So what's normal for poop? Poop has a little bit wider range. We should poop anywhere from 3 times a week to 3 times a day, and it needs to be soft formed and non-emergent. As long as it's soft formed and non-emergent, we sit down, we hopefully elevate our feet up on a little stool, we relax our pelvic floor, and our colon pushes the poop out. In heart health specifically, Boots, this is a big deal. If we strain to push poop out, we could bring on a cardiac event. Not okay. In general health, it's just your bladder pushes your pee out, your colon pushes your poop out, and if you have a uterus and you're pregnant, your uterus pushes your vagina out, or your uterus pushes your baby out. And if we're straining, then we actually can push other stuff out that's not meant to come out, like a hemorrhoid. We could cause a bladder prolapse. We could cause some pee incontinence if we're always constipated and pushing poop out. So that's important. When you poop, are you able to sit down and relax and have that poop happen, like, under 1 minute, honestly, in general? Okay. And then it's 1 or 2 wipes and we should be done. Like, it should not take half the roll of toilet paper to clean up. And if it does, that's something that's called smearing, and that's, again, abnormal, something we can work on.
And I have to interject that I do know of someone who died of a cardiac event on the toilet at work. It was so sad.
Right? Right. And we'll talk about that. Like, and like, yeah, if we don't talk about it today, we're going to talk about it in one of these segments, but like, it's a big deal. And it's something that we need to talk about first and foremost from a primary health perspective. But secondly, your listeners, this is open heart surgery with Boots. So people that are here, we have a vested interest in managing this arterial pressure. So if you've been a terrible pooper your whole life, guess what? It's time to change, and it can get better, especially in the post-surgical phases with all the medicines. Oh my gosh. Like, we really need to understand what goes into poop. A whole poop section. Woohoo! Again, there's so much we can do nutritionally and hydrationally and musculoskeletally to set you up for poop success. And the greatest thing about all this is it's going to be overwhelming for some of you listeners, and just please don't be overwhelmed. You have access to this. You can watch this a zillion times. Take notes. You'll absorb what you're ready to absorb. The same specific and simple things that will help improve the pee function will improve the poop function, will improve the bedroom function. So please just be kind and curious and not overwhelmed with all this, because this is a lot of stuff that we're going to cover in 30 minutes. Okay, sexy time. The bedroom is for two things: sleep and something else, my friends. And something else, the intimacy. It should be pain-free, unless you want it to hurt, but that's a whole different talk. But intimacy should be pain-free. At the start, you should be able to experience a pleasurable rise to a climax, which should also be enjoyable and pain-free, and we should have no pain afterwards. There should be no leaking of pee or poop during intimate functions, and we should not regularly have urinary tract infections following. There are some basic things that, with hygiene are good to follow, but if you're always getting a UTI every time after you're intimate, there's probably something else going on, and we're going to talk about that in a moment. That is, and if you are still menstruating, if you have a vagina and you're menstruating, this is going to blow your mind. Periods should be pain-free.
What?
Complete. Yeah.
But wait a minute.
Yeah.
I'm just thinking about how it is just. I'm just thinking about all my years. Like, I've been. Hold on. I just need a second.
I know, right? I know. Me too. So I am a double board certified doctor of physical therapy, one of like 100 doctors of physical therapy in the world, double board certified in pelvic health and orthopedics. I just learned this less than 10 years ago, that periods are supposed to be pain-free. And I didn't even believe it when I think maybe even 5 years ago, because my boobs have hurt my whole life until I learned this. My labias, that's like the part you can see on the side of the vag, like those would always be very sore the second day of my cycle. I made a few specific changes and pain-free. It's insane. And we don't know this. We normalize pain for women, and it's not okay. And when we can do things to control the pain, which again are a lot of the same things that I'm going to talk to you about, we can make your periods pain-free. And if we can't, and especially if they're debilitating, that can be a sign of a condition called endometriosis, which is something totally separate, and you need to get your cute butt in for appropriate treatment. There's a study of women, especially younger girls, who've ever missed school or work due to period pain. Almost 100% of them have this condition called endometriosis, which is super debilitating. And we are like, oh, it's just period pain. And we just shove them, oh, just take this medicine. And it's like, no, listen to them. This is a huge deal.
Well, and I'm just thinking about all the marketing from like the ibuprofen, Aleve, Motrin, and it just seems like it's just accepted and that's just how it is. And so you just have to take this and then that will make your periods better. I think I've had my period for maybe 30 years now. And I just assumed that was just part of being a woman. That's so infuriating.
I know, right? Isn't it? So we'll talk about the things that we can do to change that. So that is the basics of like what's normal. Now, if you were coming to see me one-on-one, we would touch very lightly on each of those things. I would have on your intake though, your chief complaint, your reason for seeing me. So I might spend a little bit more time on one of those items than the other. we would then go into educating to the muscles of the pelvis and the core and explaining how those things happen. So we would begin with the bladder, because pee urges and pee leaks are one of the primary reasons that someone might come to a pelvic floor physical therapist. And your bladder, and for those of you who can see this on video, we have your cute little bladder here that kind of rests upon a shelf that is the pelvic floor. And that shelf, I'm going to hold up Patty the pelvis here, who is an anatomical model of the pelvis. And essentially, white parts are bones, red parts in general are muscles. And we have the bony pelvis is like the structure of the house, the drywall. You've got your low back in the very back, and then you have a ring of pelvic bones that are made of your two hip bones and your sacrum behind that kind of form this circle, right? That's the base of your core. You have tummy muscles that help dynamically support this pelvis in the front and kind of connect the two pelvic bones. You have butt muscles that go from the back of your hip bones to your leg bones and back. And from my humble perspective, most importantly, you have this incredible hammock of pelvic floor muscles that form the bottom of this bowl. And those of you that can see, I know, right? They go from the front of your sacrum all the way to the back of your pubic bone.
That is quite the hammock.
Right? And get this, girl and boys, everyone who's looking, watching, it's not just one muscle on the bottom. It's a whole group, and I highly recommend, if you can, check out the video to do so at this exact minute. It's more than 13 muscles on the right and the left, just like you have right legs and left legs. And this one here is a vag. You can see the two holes, but penises are not that different. Really, it's just this top hole is kind of closed, but it's mostly all the same muscles internally. They all have different roles: constricting the urethra, the P zone, elevating the middle of the perineum, which is that muscular middle support, controlling the rectum and back, helping you keep your balance, right? And like, what? It's amazing that they ever work in the first place. And truly, so you've got this cute little bladder resting on that hammock. And in real life, and already right now, you listeners, you Boots, know more about your pelvic floor muscular anatomy than probably most primary care providers.
Just from this last 3 minutes.
Just from that last 3 minutes, because most primary care providers in medical school got one lesson on the pelvic floor that was taught by possibly a pelvic floor physio, possibly just a physio. And then they went on to quote unquote more important things, right? They went on to medicines to help save lives, to surgeries to help save lives. So this is not to minimize or say that they're missing something, but they just had to go down a different road and they never got this education. And now you are, though. And so you can be your own advocate. All right, so we've got this cute little bladder resting upon that hammock of pelvic muscles. And the pelvic muscles are like an elevator in a 4-story building. And they're meant, when they're super happy and healthy, to rest on the ground floor of this 4-story building. And then with day-to-day life, the brain should automatically decide how much muscles to use when you stand and walk and run and pick up your groceries. It should decide to bring the muscles up to that 2nd, 3rd, 4th floor and back down again. When we sit down to pee or poo, it should know how to relax them into the sub-basement and then come back to that ground floor again. They're kind of like always on standby. Pelvic problems primarily occur pelvic problems, including leakage, right? Mm-hmm. They primarily occur not because the pelvic floor is sloppy and loose and open, but because, for a variety of reasons, it starts to rest too tight. There's your second big mind-blowing thing of the day. Because for most humans, when you start to have any type of pelvic problem, we are going to do Kegels. And that's totally the wrong thing to do. Kegels are the least important part of the pelvic perspective, and they will typically make pee leaks, make pain, make sex worse. Whoa.
But I hear that's like the main treatment for everything.
And who told you that?
Yeah. I mean, it's
You
just
just
like
and
that common
you
knowledge
just
out
know.
there.
Yeah,
I
you
don't, yeah.
just isn't that funny? You just know, and that's because it's and I don't even know, like, well, I do know, actually. So, the Dr. Kegel in, like, the I don't even know if it's the it had to be before the 80s, like, where the Kegel came from was oh gosh, I'm gonna get you the specific study. Um But here's the dirty truth about Kegels. People were just told to do Kegels because if you're leaking, yes, and clearly the pelvic floor must be weak, so you should tighten them. So this is the 80s. There's not even cell phones yet. All phones are still connected to the walls, right? There was a landmark study by Bump et al. That told people to do Kegels. Then they followed up and they found that just telling someone to do Kegels, if you had 100 people, by sheer luck, 1/4, 25 of those people would get better. However, the same amount, 25%, would actually get worse, and half of the people would not see any change. And that's because there was no actual education and connection to the muscles. So let's bring it back to our elevator analogy, right? The way the body reacts to pain, dysfunction, and stress. And Boots, your comment in the opener, in your open heart surgery journey, you were not treated holistically. You did not receive this education into what happened beyond the physical heart. The pelvic floor has a direct connection to your amygdala, which is your emotional center of your brain. If we show a college-age woman with no history of abuse or stress beyond life a picture of a dark parking lot, her pelvic floor will clench because it senses the potential for danger. Whoa, this is a survivalistic standpoint. If we are physically stressed, emotionally stressed, the amygdala tightens the pelvic floor, brings this elevator up to the second or the third floor as a sympathetic fight or flight response to help us get ready to run away from this tiger, right? And now, like, and heart surgery is stressful. My Lanta, it's stressful, right? Life is stressful. That's going to start to bring this up to the second floor. And it's something that happens that we're not cognizantly aware of, right? So we don't, if I say relax your pelvic floor, you think it's already relaxed. So now I'm resting on the second floor here. My pelvic floor is doing too much work all the time. That's going to irritate my urethra. That's going to maybe annoy my bladder, so it starts to send a more urgent signal. And depending on everything else that's happening upstream, that now that these muscles are doing too much work all the time, they might not have energy to hold my pee in when I need to. I might start to pee my pants. And now we have this like net downward spiral. Now that's stressful. I might, because I quote unquote know that I'm supposed to do Kegels, I might try to tighten up more. And now I'm resting on the fourth floor, and lo and behold, my urges and my pee leaks get worse because the problem's not that my muscles are so loosey-goosey, that I've been in a wall sit for 18 years and now I'm asking myself to go run a marathon. Like, it's so sad.
Well, and I hate wall sits.
And I have really silly Instagrams. I'll get you the links that we could put under about how these tight muscles can cause leaks, but they also cause pelvic pain with intimacy because they close the door, essentially. They cause us to be unable to climax because the muscles that are associated with climax are high performance muscles. So if they're not healthy, we're not going to be able to build into a climax. We're not going to have one. If we have a penis, we might not be able to have an erection. And that's a huge deal that we're going to talk about in the next segment. It's an independent risk factor for major adverse cardiac event. Period wise, guess what? Are you ready for your third mind-blowing topic? Okay, ready, Boots?
It's been mind-blowing for 30 minutes already. Like,
oh no, it's already 30 minutes. Well, we might have to divide it into two.
That part. No, I'm just saying all of this has been mind-blowing.
But this is why we need to talk about it, because there's so much, right? So here's these sweet pelvic muscles again. For those of you that can see, I'm just showing I'm inside the belly looking down. There's all these different pelvic muscles. Here's a vag. Guess where these muscles, I'm pointing to the muscles kind of on oops, that was the rectum. Trust me, I'm a doctor. Here's the vag. These little muscles on either side of the pelvic floor. You know, if you have a heart attack, where do you feel the pain? By common knowledge, Boots. Is it in your heart, or could it be elsewhere?
Well, the two I've had,
Yes.
my left arm, the
Yes.
first one, my left arm, my chest, but the second one, here's the crazy part. The second one, I had no pain, but I
No.
had stopped peeing.
No. Oh my gosh. Okay, that's wild. I can't wait to dive in. So, first one, had we worked on your arm, it not only would not have helped, but you might have died, right? like not understanding where the pain was coming from. These pelvic floor muscles that live on either side of the vagina and then even further back towards the rectum, their referred pain pattern, they don't tip it, they could hurt in the vulva sometimes, they could hurt in the pelvic floor. Their more common referred pain pattern is the lower abdomen. So that's where your period cramps can come from in the absence of endometriosis. The pelvic floor resting too tight. During the period process, there's increased inflammatory chemicals. Everything's resting just below the pain threshold. Here comes the period. Here comes the chemicals. Boom, we cross the pain threshold. And we can put a hot pack on our lower bellies as much as we want, and it might help a touch. But we actually need to do is relax the pelvic floor.
Dude.
Wild.
Yeah.
Right? I know.
Wow.
I know. And then the third hole moving backwards, is the rectum back there. So we have that sweet rectum. Where's my rectum gone to? There it is. Found it.
Does it have a name? Because we've got Patty Pelvis.
Patty the rectum does. I have Patty the pelvis, and it alternates between Peter the pelvis and Philip the pelvis. The rectum doesn't have a name, though. I should name it. Randy? Randy the rectum? All my friends named Randy out there. I'm just gonna tell them that I just named my rectum Randy.
Yeah. You heard it here first, people on Open Heart Surgery with Boots.
Yes, Randy.
Yes.
Randy the rectum has been named, and I like it. We're keeping it. So you got the rectum back here, and remember that hammock of pelvic muscles, right? Same thing happens back here. It's meant to rest on that ground floor, come up to support our pelvic pressure during life, relax to give the on switch to the colon to push the poop out. When that pelvic floor starts to elevate in response to life stresses, in response to physical pain, in response to, oh gosh, I'm having pee problems. Now, we not only have the problem that it's much harder to relax and open the door to give the on switch for the colon to push the poop out, we're also engaging a backwards reflex called the rectal anal inhibitory reflex. We'll talk about this in the poop one. We're engaging a reflex that the brain thinks we're running away from a tiger and we don't have time to stop and poop. So the brain's going to push the poop back up the tube to give us a little bit of time to escape the tiger. But that's meant to be like a very short-term solution. So what if we're resting up on that second or that third floor for days, weeks, months, years on end? Our poop is always getting this negative signal, and so that's going to elicit typically more of a constipated trend. So the poop's going to be harder to come through. It's going to be harder for us to relax and give the signal for the colon to push out. And then if we're straining to force the poop out, now there's all the other problems, the collateral damage, so to speak, for the heart system and for the pee and the vag if we have one, right? So the key in all of this is to, number one, understand that. Because before these last 30 minutes, Boots, have you known any of this?
None. Zero.
And you are a very educated woman, and you are in this heart surgery world, and you're an active human, and like you've had a period your whole life. So isn't it just mind-blowing that we don't know this?
Well, I think how unfair it is. It just leads to so many unnecessary mind, body, spirit issues that could be so avoided. Just to like talk about how I'm educated, my undergraduate degree is in biology. My graduate degree is in education. I taught high school science. So it's not, and I also taught at the collegiate level. I'm naturally curious. I'm almost 47 years old, and I'm just now learning this. So I just want to like lay the groundwork of like really what the fuck.
Exactly. And you think about like what happens. So we look at all these studies about, that gap in care that like for most people, they're going to wait at least 5 to 7 years before they talk to a physician about their pee problems specifically. And then depending on that physician's education, like what are they going to do? Like now, if that person isn't watching this podcast, if they're not following me on social media, what if that physician's like, oh, here's a pill that's going to, like, let's say it's pee urgency, that's going to calm down your bladder. Does that fix any of this musculoskeletal stuff? It doesn't.
No, it's a
And so
That's what I'm hearing. I'm hearing
well, it is, and it's not without risk. There is the same things that pill works on to relax your bladder. It interferes with your cognitive function. And people don't know that. There's not like informed consent. A poop problem. Right? If the doctor knows about pelvic PT, which again, our success rate is 80%. So we can help 4 out of 5 people that come into our door with pee problems, prolapse problems, sexy time problems, poop problems. We can help without medication and without any nasty side effects of surgery or medication. The 1 out of 5 that we can't help, we educate the shit out of you so you now understand your pelvis and you are essentially prehabbed for success for whatever that next step might be. And we can help guide you to, hey, based on our experience, this should be the next step, because surgeries are not always bad. Open heart surgery saved your life. Prolapse surgery, bladder surgery, sometimes you need a colon surgery. They're all amazing in the right place. But just like you would never have a knee surgery, like an ACL, and then be like, oh, well, just rest 6 months. You'll be fine. You'd maybe survive, but you would not thrive. You should never have a pelvic procedure. Ideally, we'd always have prehab, but you should never have a pelvic procedure without post-operative pelvic floor physical therapy. And that includes appendectomies, gallbladder surgeries. That includes open heart surgery. I know it's not a pelvic surgery, but it's a whole body surgery. And so that should be a part. And it's not yet a standard of care, but we just talked about what happens to the pelvic floor in response to stress, right? There's not much more stressful than open heart surgery. And then we died.
Oh, sorry. I just wanted to interject in that because, and I'm going to get real personal here for a second.
Yeah.
I'm thinking post-op for me. And if you're just now finding this podcast, first of all, I'm tickled you're here. Thank you so much. And I hope that you will subscribe and you'll visit our Patreon and you'll go back and listen, because I've been building a whole network of resources for you, heart patients and caregivers for thriving post-surgery. But I bring that up because I want you to go back and listen to my story in episodes 1 and 2. And I definitely talk about the first few days of just how my body needed to purge. And one thing I wanted to bring up, I threw up 25 times post sternotomy, which was just hell on earth. But then I obviously couldn't poop. And one question I have for you, Kelly, is, you hear about post-surgery, you can't poop. And granted, I had the pee tube in for a few days, getting the fluid out of me, and that was fine once it came out. But I couldn't poop, and I needed to poop. I knew I needed to poop. And so then I drank a diuretic. But then then I couldn't control it. And so I just like to say I took advantage of all the CNAs on the floor. That's why they're there.
Exactly.
And that's like such an intense experience. And if we, in these last few minutes of this first installment, can we talk about that? Because it is so important to poop post-surgery, because I have 2 pages, single-spaced, font size 10 list of all the medications that were put into my body during open heart surgery that needed to come out.
Right, exactly. No, this is such an important part of the discussion, Boots. And we should do, we'll do like a whole thing just about pooping. But in general, the key things that you can do, there is a very simple, easy belly massage that we could start, and we honestly should start these things that I'm about to say, we should start them pre-open heart surgery as well, because they are all going to be things to help connect to this pelvic floor and calm it back down. The one additional part that also contributes to that tight pelvic floor beyond the physical stress and the emotional stress of the surgery, breathing, right? How, after a sternotomy, how was it to breathe? Suzanne, you had respiratory therapy, right? So
Yeah.
breathing's hard, and we're not going to get into too much except to blow your mind a fourth, possibly final time of this talk. The pelvic floor muscles are an accessory muscle of breathing, which means that in their perfect state, when we are relaxed and those cute little pelvic floor muscles are down here, I got Randy the rectum, when they're down here on the ground floor, we're totally relaxed. You breathe into your belly and your belly gets bigger. And you exhale and your belly gets smaller. Diaphragmatic breathing, core of every post-open heart surgery. Do they ever once say, hey, tune into your pelvic floor as you inhale and your belly gets bigger? Your sweet little pelvic floor is up here on the third floor. Can we inhale, belly gets bigger, pelvic floor drops towards the ground floor? Can you exhale, belly gets smaller, pelvic floor stays relaxed? Inhale, belly. Of course it was never mentioned. And pelvic PTs are making great strides in OB floors. Finally coming in to see women post-baby, post-cesarean, hugely important. It is just as important for us to start to have a presence on open heart surgery floors and in the ICU, or even collaborating with your respiratory therapist. But that singular piece of belly breathing, step one. Again, pre-heart surgery, we are super stressed, right? If we are able to, if it's not this emergency thing, we know this is coming, we're very stressed, our pelvic floor is going to be up here. So we owe it to ourselves to do some of that diaphragmatic breathing to stimulate your parasympathetic nervous system, the calm, the rest and digest system, to bring the pelvic floor specifically down, to not irritate the bladder or Randy the rectum here. Now, so that's one thing, is this belly breathing we can do, and we can start that as soon as we are out of surgery. The second thing is a very simple belly massage. And what will physically happen is, at first you're going to say, well, I can feel that belly moving, but I can't feel anything back here. And that's just curious. We're not angry that we can't feel that, but we're simply curious. And that's going to give our brain permission to try to find those nerves, because I guarantee they're there for you. In a future one, we'll go over the exercises, but just being aware of that, and possibly even sitting on a little rolled towel vertically. So a little pressure on the vag or the part behind the scrotum, a little pressure on the rectum. Inhaling, try to encourage those pelvic muscles to come down is huge. Secondarily, belly massage. Those of you that can see me, I'm going to stand up here. Here's my belly. You would have a big old incision here. We would be laying down, and this is my belly button. This is clockwise. I never know what direction my video shows up, but we would be laying down relaxed, and we would do gentle pressure, gentle circles in a clockwise direction. This is called sunflower massage. And old school I love you massage is fine. It's better than nothing, but I'm going to give you something better. Old school I love you massage is you would do an I coming up from the right hip here, and then an L up and over, and then a U. And that's fine. And the theory is that you're helping to move the poop through the tubes. I want to be very honest that in real life, you're simply mobilizing the nerves and the blood vessels, but it has an exquisite benefit, okay? So you would spend 3 to 5 minutes of this sunflower massage just feeling your tummy, and it should feel like soft bread dough. And you might get to a spot like mine's not moving the greatest right there. That's interesting. So if I was having any poop issues, that would be good for me to just gently work on. We would never poke into a spot that was sharp pain. If for any reason you had any insertion, any ports in here during your surgery, then we wouldn't want to be doing this. But in open heart surgery, we normally don't. But we would do this 3 to 5 minutes of this belly massage while belly breathing. Okay. Then we would follow it with the PT version of digestive massage, which is actually going to start at the out hole. Randy the rectum here. I didn't talk about this at first. We just talked about where he was in relation to the pelvic muscles. He's actually turned 90 degrees. So your poop at the end of its journey through the tube has to make 2 turns, 90-degree turns. And that's kind of unfair. That's called your sigmoid colon. But to clear that, you're going to go find your left hip bone. You're going to come to the inside of it. And you're going to push in and then pull towards a line between your belly button and your pubic bone. So you're going to push in, pull here, and then release. And you're essentially clearing the sigmoid colon. We might be pulling poop into the final holding stage. In reality, you're massaging all the nerves that are going to that colon and helping it move more freely. And you're going to do that 3 to 5 times while belly breathing and trying to relax your pelvic floor. And now we've opened the door a little bit of the pelvic floor. We've softened it to take the brakes off the colon. We've started to move here. Now we can push here. And this is something that if your arms are tired, if this amount of pressure is sore from the sternotomy, a partner can help with this. You can use a silicone massage cup. 3 to 5 times pushing downwards to help the poop down the descending colon. And again, in reality, just mobilizing all the nerves that are going to the descending colon. We would then do transverse colon, and this depends on how low our incision is, right? So we're always going to be healthily below the incision, and we could even have a second hand on the bottom of it to make sure we're not disrupting that. And we would go 3 to 5 times across. It doesn't matter that my actual colon is like up here and way back there. This is the nerves that are going to the colon that we're working on, people. Then second to last is ascending colon. I start at the lower right and I pull up. And the whole time I'm just, any place where I've just created space, now I'm encouraging poop to move towards, or I'm encouraging the nerves to be healthier. Final one is your cecum, where your small intestine meets your large intestine, and it's the mirror of our first one. We push to the right and pull over 3 to 5 times. Doing that relaxed breath frequently throughout the day, doing that colon massage 2 or 3 times a day. And then when you move, exhale with exertion. Exhale as you log roll to the side. Exhale as you push up to the edge of the bed. Exhale as you stand up. That's going to help the deep tummy muscles do the work so that the pelvic floor can stay a little bit more relaxed. And then when you do exhale, when you sit down on the toilet, you might have an elevated toilet seat, which is kind for the core muscles. But when the hips are kind of lower than, so the ideal poop position is that my knee would actually be like higher than my hip. So if we're on an elevated toilet seat, we might ask a caregiver or a nurse to bring in a stool to rest our feet on. So we have more of like a 90-degree angle. And then we could put, typically we say pillows, but honestly they're not, they're a little soft. So if the nurse could bring in like an extra set of sheets that have like a little bit more firmness to them. And I'm sorry, I don't have one with me right now because I didn't think we were going to talk about poop so much, but we would sit on the toilet, elevate my knees up a bit. Those of you that are here watching, I'm giving a great visual demonstration. And then we would push the towel, the folded sheets kind of against the low belly while we just tried to breathe and relax the pelvic floor. And that's setting up the system as much as possible to push that poop out. And essentially, we never want to strain ourselves. And the medicines that you need to clear, you will need the stool softener in general to have that happen. So if you do have then the poop emergencies and the poop accidents, if we needed that drug to get the poop out, it is a common thing that might happen in the ICU or in, the transitional, and just know that the nursing staff is there to help you. Don't be embarrassed. And then the next poop, as we wean off of those, we can do all of those good things that we just talked about. And pooping your pants, vomiting, it's all super stressful. So again, just coming back to, can I just belly breathe? Can I tell my body, this is super freaking hard and this sucks, but thank God I'm alive. And can I experience all of these feelings while relaxing my pelvic floor? Understanding that collateral damage of the pelvic floor tightening is going to happen in response to all of this. So let's soften it. Oh my
the
gosh.
mental game is everything.
Girl.
Wow, that was quite the initial 101.
Yay, Pelvic
Thank
PT!
you.
You guys are so welcome. And I know it's a lot, but I have we're going to do a lot more segments together for this February Heart and Pelvis Month. Pelvicfloored.com is the website where we have lots of blogs that are getting repopulated. There's going to be more and more dropping each day. Instagram at The Real Pelvic Floored. I take my job seriously and not myself, so I have a bunch of silly videos about all things pelvis. I have a small newsletter that's getting a big revamp in 2025. Please access all of that information. We're going to do a lot more talks, but whatever questions you have for Boots and I, please submit them because you are not alone. You are not the only person with this question. So you asking that question is going to help so many others. You can work with me in person or online, or I have a great blog about how to find a pelvic physio near you. That's amazing. If you have questions, again, send us a message. Here's where you live. Here's what you're wanting help with. I'm happy to physically help you connect with a pelvic PT in person near you. And then lastly, I do have online resources. There are some courses that you'll see, as well as a newfound treasure chest that has a little bit more in-depth information and exercises than the Insta. And Boots and I, as gratitude for you guys being here, you can use the coupon OHS 2025 for 25% off any of those online programs. And if you did do the treasure chest, that would give you 25% off the first 3 months. So I sincerely hope that's helpful to you, Boots. Thank you from the bottom of my heart for having me here. This is so fun. I cannot wait to talk about poop more. I love talking about poop. And to talk about erectile dysfunction as a primary risk factor for major cardiac event, and so much more.
And so much more. So if you are in hysterics now, just wait for the rest of the month. We can make this fun. Talking about poop and sex and the vag and penises can be fun.
It can be.
And it doesn't have to be shameful. So be sure to come back next week. I'm so excited and I love you. You matter. And your pelvic floor is your best friend along with your heart. Come back next week.